Hi, Campfire. This is Dr. Parmar, and I'm here with Dr. Jeff Donovan of Donovan Medical. He has so graciously agreed to do this interview. Dr. Donovan is somebody who I've been following for a number of years on his social media, on his Instagram at Donovan Medical, as well as his blog. I've been learning so much, and when I asked Dr. Donovan to do this interview, he graciously said yes, so that we can get some of your questions that you've put in for him answered, hopefully, and that we can, have access to some of his expertise that we normally wouldn't be able to get. So, hi, Dr. Donovan.
Hi, thanks so much, Dr. Parmar, for this invitation.
Oh, my pleasure. Actually, my first question is, how did you get into the hair business?
Hair always fascinated me. It's an area where it really can change people's lives, and to see the profound effect that it has when you stop hair loss, give people back hair, grow hair, it's incredible, and it's a feeling really like no other. And someone once said to me that as you think about what type of specialty you'd like to do, think about the last patient of the day that you're running 2 hours behind, and who is the last patient of the day that you'd like to go in to see? Is it a toenail fungus? Is it a eczema? For me, it was hair loss. It's a hair loss patient that really is someone that I feel like I'd like to help. And so it was a very easy decision for me.
That's actually a really great question to ask of a clinician. Like, who is the person, not the person, but what is the case or the situation medically that you look forward to helping the most? I think I do that, actually. I've never asked myself the question, but there is a person I'm thinking of, or a kind of person I'm thinking of, that I'm like, oh, I actually would love to squeeze that person in, even though my shift is over, because I actually look forward to seeing that kind of thing. I actually really like that. That's a really good practice kind of motivator as well. So you've been in the hair business as a dermatologist specializing in hair loss for how long?
About 11 years.
Okay. And one of the things that we are taught in school, in naturopathic school, it probably comes from some conventional understanding of hair loss, is how to assess a person who is complaining that they are maybe losing their hair and they're not exactly sure. And it's called the tug test or the pull test. Can you walk us through that a little bit? Because I've heard 400 different versions of this, and I don't know which one's right.
Yeah, and the real answer is that there still is a lot of debate about what is right. The best way, and I'll come to the formal definition in a minute, the best way to know what is normal and abnormal is to just start pulling people's hair.
Oh, okay.
And over time, you will realize, whoa, that's not normal. Even if you don't have this magic number in your mind of, is it 3, is it 6, what is the number? If you start just, when you're examining patient's scalp, pulling hair and seeing what comes out when in the normal situation. Let's say a patient is coming in for, some other issue, and you say, I'd like to just examine your scalp, examine as part of my routine exam, and you pull hair, they don't have any hair loss concern, and you realize that, I got one hair out. Over time, you'll come to realize when you meet an abnormal pull test that this is strikingly different than I've ever had. So that's my first pearl, is you can focus on these numbers, which we'll get into now, but start pulling people's hair and you will come to realize instantly that's abnormal.
Do you mean the same person serially that will be able to tell that there's a change, or between people?
Between people.
Okay.
And so what you'll realize in the clinic is when you pull hair, you'll realize that, gee, I don't get any hair.
Right.
And then you'll pull the next patient's hair and you'll say, I really don't get any hair. And then you'll go throughout your week and you might get 1 or 2 hairs. Probably you'll get no hair. And now you'll walk into a room and you'll pull hair and you'll get 3.
Yeah, okay.
I can assure you that's abnormal.
Okay.
But if you have in the back of your mind, it's got to be 6 or more.
Yeah.
You're going to miss a telogen effluvium. You're going to miss a key diagnostic kind of phenomenon. So
that's so important, because I think one of the things that we see a lot, and the reason why we end up referring necessarily to dermatologists and doctors like yourself, is because it's never really clear for us in our world of like what constitutes hair loss or what constitutes a problem, because so often a patient will say like, I'm getting clumps in the shower, or my brush has a lot of hair on it, and then you do your own little test and you're like, well, I'm not seeing what I would expect to see. But I guess your advice is that if it seems like it's abnormal or is in context of some clinical picture that is abnormal, then that constitutes something to consider.
absolutely.
Yeah, okay.
And so, I really think that anything 3 or more on a typical pull test is abnormal.
Okay.
But the most important pearl that I teach is that I don't really even do the pull test.
Oh.
Patients want me to do the pull test, because if you don't do the pull test, patients who know the pull test will say you didn't do the pull test. I really trust my patient's judgment. Nobody is a better evaluator of their hair than the patient. And so if the patient says, when I'm in the shower, I get these balls of hair and I stick them to the shower wall. I never used to have that. I never used to have that.
Right.
Guess what? You're shedding more than normal.
Yeah, okay.
Doesn't matter what my pull test shows.
Mm-hmm.
I'm probably going to do it because,
Mm-hmm.
Maybe this is a patient who knows about the pull test.
Mm-hmm.
But that patient has told me that they're shedding more than normal.
Mm-hmm.
And so it's the history that really guides me a lot. I say to a patient, do you feel you're shedding more than you used to 2, 3, 4 years ago?
Mm-hmm.
And patients know their hair and they will say, absolutely, absolutely, I am.
Mm-hmm.
This is an abnormal shedding phenomenon. And
There
so the
are,
history
yeah.
is key.
It's so important because a lot of the times we're trying to capture a diagnosis, or at least wonder if the diagnosis is even there that we need to refer on to. And there are 3 things that have been suggested as useful tools to find out if there are other pieces or markers that suggest that hair loss is part of this person's picture: ferritin, thyroid, and DHT. 3 questions I have with you of those 3 is there a specific ferritin cutoff that is associated with hair loss and hair regrowth? And then I'll get to the thyroid and the DHT after.
The ferritin is really a wonderful topic, and one that I could talk a long time on. The short answer is there's not.
Okay.
Everybody loves to have their cutoff because it allows them to feel comfortable with the situation in front of them. But there have been at least 4 or 5 studies that are good studies showing that really and truly there's no ferritin cutoff that is really all that helpful.
Oh, wow. Okay.
And that comes as a surprise, I know. I think in the hematology world, they will say to be 99% confident there's no iron deficiency in the patient, you have to have a ferritin above 70.
Mm.
To be 95% confident that everything's okay, you have to have a ferritin above 40.
Mm.
And so we get those arbitrary cutoffs from the hematology field. But when it comes to the hair field, the studies have taught us that those rigorous cutoffs don't really apply. I do think that if a person has a ferritin of under 30, we are getting into the possibility that it could be related. Most likely it's not, but it's possible. Once you start getting a ferritin in 20 and 10, then you're increasing the likelihood that this could be involved. So my cutoff in the clinic that allows me to feel, I think this is okay, is 40. But I also like to look serially at ferritin and hemoglobins. So if a patient once had a hemoglobin of 140 and a ferritin of 55, and now they have a hemoglobin of 110 and a ferritin of 20, then it's telling me that, you know what, maybe that ferritin of 10 or 20 is too low. So I do look at the ferritin and the hemoglobin together to get a sense. So I use a cutoff in my clinic of 40. And if it's less than 40, I replenish with iron.
And then your goal, if a person is still experiencing hair loss after achieving that threshold, will there be another threshold that you try to get to? Or is it like, no, it's just less likely or unlikely if you're there?
That's right. So if you have a ferritin of 40 and you're still shedding, then in my mind, we're moving on. This isn't an iron issue.
Okay.
And so it's a helpful thing that let's go investigate something else, because something else is probably the cause.
Bark up a different tree because you've probably solved that one. Okay. What about thyroid? I mean, this is a huge topic.
Yeah.
So what should we as sort of just general clinicians be looking at for like a TSH or even maybe a T4 if that's relevant for somebody who's experiencing hair loss?